Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Something like that. Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
I'm James Larkin.
Good.
I did it again. Did I do it again?
No, you did a good level there. Normal level. Okay, we're going to talk about the LEAP-004 study, Lenvatinib-Pembrolizumab in melanoma, and then the subsequent phase 3 LEAP-003. But before we do, James, let's do what's your number? What is what's the number of kilos you're deadlifting right now?
Embarrassing.
You're off on holiday, so.
No, but because I was injured, right? In 6 months ago, elbow.
May?
No, March. I know exactly.
Okay.
So I'd stopped deadlifting because it's quite. There's a lot of grit, right, and strain. So I did it for the first time in 6 months on Monday, and Owen wouldn't speak to me. Owen, the coach, wouldn't speak to me afterwards because he didn't think I was trying hard enough with the weights on the bar. So I'm not sure I can say that in public.
Well, be careful calling him out. He's going to end up playing this episode in your gym then.
Yeah, but this is all true. I said, Owen, I haven't deadlifted for 6 months. I'm not going crazy. I've been injured, and literally, he wouldn't speak to me. He deliberately walked past the bar.
Oh no!
Like looking at, so he's like in a seriously bad mood with me at the moment. So you need to ask me that question another time. But actually, on a related subject, now I think my injury's better. So I've been back doing pull-ups and stuff like that, and actually it's all been good. So I haven't reactivated my injury. So I'm kind of.
Well, that's good. How many pull-ups can you do? What's your number of pull-ups?
Oh, strict. When I don't weigh 93 kilograms because I've just been eating.
That's your number.
For 3 weeks. I think I can do about 14 or 15.
Wow.
When my body weight is appropriate. At the moment, I don't think I'll be getting close to 14 or 15, but you know.
Nice. Good. Okay, well, let's talk LEAP-004. This is Anna Aranche, first author, Georgina Long, senior author, and this was in JCO in June 2022. Or it was 2022. Let's not commit to the month. And this was Lenvatinib-Pembrolizumab for metastatic melanoma that had seen PD-1, if I'm not getting that wrong, I think. And it was within 12 weeks of that last dose of PD-1, whether that PD-1 was monotherapy or in combination. So first of all, maybe we can talk about why Lenvatinib. Why was that even a drug studied in this area?
Yeah, good question. So, I mean, worth saying, I treat kidney cancer as well. Lenva-Pembro is an approved first-line treatment for kidney cancer. So it's reimbursed here. So not all the treatments are. But so we've used it quite a lot. Lenvatinib's been around for a while. It's actually quite an interesting drug. Its original name was E7080, I think. And if you go back to the ASCO abstracts from 2009, 2010, Eisai's the company, there were some responses in melanoma, actually, in non-randomized trials. And then not much happened, I guess, with this drug in melanoma, at least for quite a long period of time. And actually, there's another label in kidney, which is Lenvatinib and everolimus. So that's a sort of different story altogether. So this is a multi-targeted VEGF receptor tyrosine kinase inhibitor. Like all these drugs, there are lots of other targets outside VEGF receptors, of which I think one of the most interesting ones is FGF receptors, plural. There's been a story knocking around for a while, certainly in kidney cancer, about modulation of tumor microenvironment with anti-VEGF. And to some extent, I think with anti-FGFR therapy, although other anti-FGFR therapies have been tested in the past in kidney cancer, which haven't really looked like they've added much. So to summarize all of that, there's a sort of a rationale potentially with this drug for modulation of tumor microenvironment, potentially in such a way that it may increase sensitivity to immune checkpoint inhibitors. And I think that's the sort of preclinical rationale. I would mention a couple of other things, though. I think that one is that, and you've alluded to it already, actually this program, this LEAP program, this combination of drugs has been tested a lot of different tumor types early on, really looking for signals. And then in kidney cancer, at least, if the FGFR story was a real one for a combination with anti-PD-1, then my question would be, is this combination superior to any of the other approved combinations in kidney cancer, Axi-Pembro, Nivo-Cabo, for example, as a consequence of FGFR? And I'm not sure we can say that in kidney cancer. I'm reluctant, obviously, to extrapolate between tumor types, but it's sort of a passing comment. So anyway, so the authors say in the paper that the unmet need we all know, which is anti-PD-1 refractory melanoma. The drug is interesting. There's a potential rationale for using it in conjunction with further anti-PD-1 therapy. And I think that's the crux of the matter. Oh, I missed one thing. Go on.
Go on. No, you go.
Which is the anti-VEGF story in melanoma proper. I mean, I alluded to it with this drug many years ago as a single agent. But also, if you look at other drugs, axitinib would be an example, kind of along the way. To some extent, other anti-VEGF drugs, I think we've known for quite a while there is an efficacy signal there in metastatic melanoma. In my view, not a big one, and not really, evidence of durable activity. But there's a signal in there. Sorry, carry on.
I mean, it's one of the most vascular tumors. You know, the sort of question to fellows is often if you have a woman who has a history of breast cancer and a history of melanoma, and then there's a brain metastasis on the scan and it's bleeding with edema, from which primary tumor is it more likely? And it's often more likely melanoma because it's a more vascular tumor, hence the potential for VEGF inhibition across many different ways to treat it or to inhibit it. Do you like this idea then of this coming in the PD-1 refractory and the modulation of the tumor microenvironment to make a tumor more PD-1 sensitive or sensitive to PD-1 inhibition? Or do you think this is a frontline strategy?
I think in principle it could be either. I don't think we know, well enough from biology, preclinical or even clinical, which one. I mean, obviously, the easier way to test it is in the refractory setting. That goes without saying, because if you see a signal there in non-randomized studies, as we're going to be talking about, you don't need to do massive trials. You can recruit them quite quickly. The difficulty always is about interpretation of the signal. We will come on to that, I'm sure.
Yeah. So in their phase 1, they had a small cohort of 21 patients with melanoma, and they had a 48% objective response rate with a long duration of response over a year median. So that prompted this phase 2, LEAP 004. So why don't you describe the schema and design of it?
So just maybe pick a few things out. So this JCO, like you said, 2022. Just over 100 patients, 103 patients confirmed PD within 12 weeks of the last dose of a PD-1, PD-L1, either given alone or with other treatments, including anti-CTLA-4. Lenvatinib dose, 20 milligrams once a day. Pembro, 200 milligrams every 3 weeks. Primary endpoint, objective response rate. So I think that's all relatively standard stuff. I might just come back to say something about lenvatinib dosing in a minute. And anyway, of the 103, median follow-up at the time was 15 months. Response rate 21.4, confidence interval 13.9 to 30.5, so dropped down from what we'd seen in the phase 1 you just mentioned. 3 CRs, 19 PRs, median duration of response was about, sorry, I'm looking for it now, 8.3 months. So, and then just something about toxicity, grade 3 to 5, 45%, most commonly hypertension, and about 20%. One patient died from a treatment-related event, which was decreased platelet count. So 20% response rate, I think interesting. Median duration of response, that's looking like a targeted therapy median duration of response to me there, rather than a checkpoint inhibitor median duration of response, or at least what we're used to in melanoma. 20 milligrams of lenvatinib, in my experience in kidney cancer, very, very tough. I don't think I've ever treated a patient with kidney cancer who can manage 20 milligrams of lenvatinib because of side effects. And what people say about this regimen is the toxicity, but it's purely related to the lenvatinib dose. Sure. I have to say, in kidney cancer, most of my patients will end up on 10 or 14 milligrams of lenvatinib.
I was just quickly looking here. It looks like that tracks here. The median Lenva dose ends up being 15 milligrams, and it doesn't come as a 15. It comes, 20, 14, 10, 8. So that speaks to dose reduction. And it says the median time to dose reduction is 1.4 months. So that's pretty quick. It sounds like people are needing to dose reduce.
Well, actually, in clinic with the lenvatinib, and it's kidney, but I think that for toxicity, it's not that different. I find if you start someone off, and the label, just to be clear, because I can get into trouble here, the label in kidney says that you start with 20, but most people will run into toxicity if they're going to within a week or two. And my practice in clinic is not to wait a long time. It's to drop the dose quickly and try and get the dose right, because otherwise what happens is that the patient needs to stop treatment for a week or two, recover if they've got really bad mucositis or skin or something, and then start again at a much lower dose. So I guess that's worth mentioning. But I think the big question really, is about this kind of level of efficacy, response rate, and then the jump really, the jump in the LEAP study from 004 to 003, which leap backwards numerically at least.
And talk about it. Is there something to say about the PD-1 refractoriness here? This was, you said, within 12 weeks of PD-1 with prior PD as the prior response to the PD-1. But does that mean these were primary refractory PD-1 patients, secondary refractory, or we just don't know?
I'm not sure we really know, and there are definitions of all of this type of stuff. But I would say that I think that the investigators have gone to reasonable lengths to define the population, so that's good. And the other thing I would say as well about this group of patients is that there'll be some people who've been labelled correctly as having progressive disease on trial entry, but actually, if they hadn't had any further treatment, sometimes some of those patients will later get benefit from treatment. So I think actually with this type of single arm study, there's probably what you might call a built-in late response to some of the baseline characteristics of the patients, which I think is something that's worthy of consideration, shall we say. But I'm not saying there's a clever or right way to do this study, but I think it's something to bear in mind.
But it goes to the point that then any observation here of interest, if it's due to a late response of just these patients, is warranted to then be studied in a randomized fashion, right? Just to make sure that it's not just a late effect of the Pembro, say. So then maybe that's a transition into LEAP 003. So this study found an objective response rate what did we say? Per eye RECIST of 29%, per regular RECIST, what did you say it was? 21%.
21 in the total population, yeah.
Yeah. So then on the basis of that, it looks like, well, yeah, maybe there is some benefit of PD-1 and lenvatinib in the PD-1 experienced population. So then it moved to LEAP-003. Now, LEAP-003, we've not actually seen in a publication. We heard it in a presentation, maybe SMR last year. I think Anna Aranche presented it there. But importantly, there was a press release that came out about LEAP-003. This press release is dated April 7th, 2023. Merck and Eisai are discontinuing the phase 3 LEAP-003 trial, evaluating Keytruda plus Lenvima for the first-line treatment of adults with metastatic melanoma. The decision is made based on a recommendation from the IDMC, which reviewed a planned interim analysis and said the combination did not demonstrate an improvement in overall survival, one of the study's dual primary endpoints, versus Keytruda alone. And the other, at an earlier interim analysis, the trial's other dual primary endpoint, PFS, showed a statistically significant difference, but it looks like they closed it because this later interim didn't have the OS difference. And so the only place we've really seen raw data here is perhaps in that SMR presentation, but in writing would be in the clinicaltrials.gov posting, right? I haven't seen this published anywhere. I think we did our diligence looking. Are you familiar enough with 003 to talk people through this one?
Yeah, I don't know if there's like a load more to add to what you said. I mean, if you look at clinicaltrials.gov, it's a decent sized randomized trial, around about 670 patients. Randomization, as you described, 1-to-1. And, you know, in many ways, that's kind of all we know. It's a shame we haven't seen manuscript. But evidently, you're not seeing enough efficacy, or enough efficacy hasn't been seen here, in addition to Pembro, to carry on recruiting the study. So it does come back a little bit to what we said before. Go on.
Well, I was going to say this outcome measure PFS here, it's 10.1 versus 4.2. So 10.1 in the combo versus 4.2. And this is by BICR, by Blinded Independent Central Review. It says per modified RECIST 1.1. Sure. They're not showing p-values here in clinicaltrials.gov, but that's already a doubling of PFS. And then, here's the p-value, 0.0295. One-sided p-value based on log rank and stratified by BRAF mutation. Great. So that turns into a hazard ratio of 0.83. Confidence interval stays on one side. And then for overall survival, the co-primary, this is very interesting. It's 25.8 in the combination and 39.5 in the Pembro placebo. So overall survival is higher in the Pembro placebo, 25.8 compared to 39.5. So that p-value is 0.95 with a hazard ratio of 1.2, favoring Pembro placebo. Very unusual.
Yeah, I suppose what you could say about all of this is we know that the toxicity for this combination is going to be considerably greater than single agent, because single agent Pembro is well tolerated.
Yeah,
and it isn't that surprising for me to see some PFS benefit, because I would sort of expect it with adding an anti-VEGF in this situation. But evidently, you're front-loading the curves, if you want to call it that. You're getting a little bit of upfront benefit in PFS, but quite a lot of extra tox, I would imagine. And actually, that isn't translating in terms of survival into something worthwhile. So then the question, about FGFR, at least in this first-line setting, might anti-FGFR treatment reverse any component of intrinsic resistance to anti-PD-1 monotherapy, I think the answer in unselected patients is probably no.
Yeah.
And so then, based on this, without manuscript, etc., what about the question about anti-FGFR therapy in, let's say, acquired resistance or refractory disease? Maybe a different thing, maybe not. I mean, we could discuss that as well. Maybe that question's still not really answered, but at the end of the day, is this going to be developed further in this disease? It isn't. And that's where we are, I guess.
Yeah. I mean, as you say, if you're front loading with PFS but not ending up with OS, feels like a targeted therapy benefit. Presumably that means if we were to ever see OS, we're going to see those curves cross because there'll be some early PFS front loading benefit and an OS curve. And you see a numerical benefit in objective response rate, 43.4% versus 35.6%. But again, the lack of OS may mean you're not really changing intrinsic resistance. So is this better off? So yeah, is this better off? As I look at the LEAP-004, the authors clearly describe here that the database limited collection of whether patients were primary or secondary resistant to PD-1. So, if you were going to develop this further, probably not in the front line, but probably in a select group of PD-1 refractory. Now, is that the primary refractory or the secondary? It might be nice to look at some of the biomarkers. If they did any sort of correlative studies here, it might be nice because maybe then you might be able to pick it out. What are you changing in the tumor microenvironment? Would that be in a primary PD-1 refractory situation or in an acquired PD-1 refractory?
Yeah, and I think this is obviously not an easy problem, heterogeneous in terms of mechanisms of resistance. The tools we're using it to measure it, are they really capturing the biology? I don't know the answer to that either. Maybe sometimes not. But I think the question is still open. I just wanted to ask you about NCCN guidelines here, in as much as you feel able to say. So this is in the guidelines, right, in the refractory setting.
Yeah.
Is there much usage? Does it stay in the guidelines now? What's the sort of, what's the mechanism? Because people might be interested to hear about that.
Yeah, I have no insight into NCCN. I'm a member institution, but I certainly don't sit on the NCCN panels. So I really don't have a lot of insight on how those decisions are made. I will say, based on LEAP-004, we saw it as a listed option in the algorithm. With LEAP-003 being negative, you won't see it as a frontline listing. You shouldn't in NCCN. But the question is, does the second line remain, and do we like the language around that? I suspect it will remain, knowing, what I've seen historically about the guidelines and how they get updated. So, I guess it's an option. But again, I don't think we have any clarity on which population to use it in. Do you use it in somebody who garnered a response to checkpoint and lost it? Do you use it in somebody who never got a response to checkpoint? Yeah, that's a little bit confusing here, I think. That's not clear.
Yeah. And the dosing can be a little bit difficult as well. So mainly it comes in 10s and 4s, Lenvatinib, at least it does here. So again, I need to be careful about labels and things like that. But sometimes it's nice to give the patients a party pack. That's what I say.
Multiple doses, like temozolomide back in the day. Here's a variety of strengths.
Few different types of party pack, I guess we're talking about here. But anyway, joking aside, in kidney, a nice thing to do, because we give the Pembro 6 weekly, is make sure the patients has enough 10s and 4s that they're able to dose, if they need to, at 18 and 14 and 10. Because if they've got a load of 10s, right, and then they can't it's common sense, isn't it? And they can't manage 20, then the patient's kind of stuck a little bit there.
So for kidney cancer, you're able to do that. You're able to give multiple strengths.
Yeah, no, and I do that in practice. I think I hope I'm on safe regulatory territory in saying that. But I think, do you know what drives me is the patient perspective here. The last thing I want to do is cause such bad toxicity. The patient's off treatment for a while. They lose confidence in you as well. I don't know how much you and I have talked about that before, but if you just get catastrophic toxicity within a week or two of starting treatment, and the patient's only recently met you, they might think to themselves, "Oh, is this someone who knows what they're doing?"
Yeah.
Whereas if you say, "Well, actually, this dose isn't, easy for a lot of people to manage. Keep in touch. We don't need to kind of kill ourselves on high dose here. We actually need to find the right dose," and that's what I say to my patients with kidney cancer. Go on, carry on.
Well, with the BRAF/MEK, what's really interesting is with dabrafenib, trametinib, sometimes that was also the experience, as you would run into pyrexia or some other things that would require you to drop the dose down. So in the US, the trametinib comes in 0.5 milligram strengths, and you would take 4 of those to get to the full 2 milligram, or it comes in 2 milligram as a whole tablet that you can't, adjust or score. So, when I have the instinct in patients, I think we're going to need a dose reduction. I would prefer to prescribe 0.5 and tell them you take 4, but on the off chance we need a dose reduction, it's going to be easier to do it. And, insurance companies just don't see it that way. So what I could not do is prescribe them a 2 and a 0.5, because, for an insurance, that's going to say that, that's beyond the approved dosage. But when I tried to do 0.5 and dispense, say, 120 tablets as opposed to 30 of the 2 milligram, it's incredible how many times I would get a denial because they would want me to start them on 2. Yeah, I know you want me to start them on 2, but I know I'm going to be dose reducing them soon. And then we're going to have to go through this whole thing at the 0.5 milligram dose to get authorization. So just let me give them 0. But it's so challenging. So I'm glad to hear you're at least able to circumvent that for kidney cancer there. Is Pembro-Lenva a regimen you can use for melanoma in the UK?
No.
Okay.
So guidelines aren't relevant to us. What's relevant to us is reimbursement. And for reimbursement, you need a label, and the data need to be scrutinized by NICE, which is our HTA body. So no, not even close is the short answer to that. And I guess that's, comes back to the importance and relevance of guidelines in different jurisdictions. Some places it's a big deal and it makes a difference in clinic, and for us it doesn't make any real difference at all, actually. So anything else on this? We've probably done it, haven't we, or not?
Good. LEAP 004, 003, Pembro-Lenva may be still used in the US in the PD-1 refractory, though which PD-1 refractory population unclear, and certainly not a frontline regimen that we'll be developing.
Very good.
Okay. Thanks.